But managing complications is what really shows how experienced and comfortable you are, because it's the most critical situations. So as we go through these things, we're all working together, and we need to learn from each other's experience. As you do a fellowship, you continue, you're beginning your fellowship. So if you're doing cases, you're going to have complications. It doesn't define you, but you need to figure it out how to limit them and how to deal with them as they happen. The best way to avoid a complication is to avoid it. In an effort to do that, you want to establish as complete an understanding of what's before you. Take the time necessary to get to that level of understanding. It's clearly hard when you're dealing with time-sensitive procedures like stroke thrombectomies. Often the phrase measure twice, cut once comes to my mind. Think through it again, understand where you're going, and hopefully you'll get it right with that first act. Again, this could translate to reviewing the arch anatomy on a CTA, or if you have an IC occlusion, you don't know what the circle of Willis is doing for you. You may have an impression of it from a CTA that was done in preparation for the case, but clearly when patients are given TPA, plots move. So I think in many instances, I will shoot the vert or at least the contralateral carotid system, maybe even just from a common carotid standpoint, just to see what's going on with the circle of Willis. It'll help you. You'll understand if there are distal emboli that you didn't cause or that you did cause, and how long that ischemic effect has been present. Okay, when, not if, complications occur. And this is descriptive, this slide, because when it happens, you react. Your reactions are based on your prior experience and your knowledge that you can apply, but you're reacting. So you're going through your ABCs. You're thinking about ICP and BP and blah, 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 trying to manage it. The time to modify your reactions is now, to get as comfortable or in your fellowship. Learn from the people training you. VLE's got a lot of that training. And much like in-flight emergencies, where you're told to put your mask on before putting the mask on your child, take a breath before you take care of your patient. Settle yourself so you can address the situation as best you can, and reach out for support. Very often in complicated cases, I'm calling one of my partners and I say, yeah, I need a lifeline, things like that. But reach out when and where you can. Okay. And this is mainly what I said. Sometimes the complications are seen. You have gross extravasation, like on that slide that Justin presented yesterday. Sometimes it's not. Sometimes all of a sudden you're noticing, oh, the microcatheter isn't lining up as well with the roadmap. What's going on? Oh yeah, the patients become a little more tachy, a little higher pressure. Yeah, maybe it's time to do a DynaCT because the patient's had a bleed that is not showing up. Not all bleeds show up. If you rupture a vessel, yeah, it's going to show up. If the patient's developed an intraparenchymal hemorrhage during a case, it may not show up. But it's as important to understand it's happening and to address it. So awareness. You can't respond to a complication if you don't know you've had one. I was assisting Alex Berenstein in a case when I was a junior fellow, and it was like a meningioma embolization on the convexity. All of a sudden he said, stop, we need a CT. I'm like, what's going on? With his training, because he trained before, really at the juncture of when CT first became available, his training in angiography was such that he was trained to see masses by vascular displacement. And he recognized that the vessels weren't in the same place they were at the beginning just from his memory. And he was right. So he had that ability to recognize that. I don't think anyone in practice now, except for Alex and his ilk, have that capability. So we've lost certain things. It's important to understand what we've lost because there may be opportunities to get it back, possibly with AI that could be applied to see those vascular displacements, things like that. Anyway, complications will erode you. The only advice Berenstein gave me at the end of the 2-year fellowship was pick your first 10 cases carefully. And as we talk about thrombectomy here, you're all practitioners, almost all. But still, pick your first 10 thrombectomies carefully. Yeah. You don't want to get dissuaded by you're trying to do a triple tandem case or something as one of your first cases and it doesn't work out well. And even if you can shoulder that burden, it is a new program in this whole region. And it may not be helpful to that particular patient. You want to be as helpful as you can. But there's so much uncertainty as you begin an effort, you just need to take that into account in your decision making. As you encounter complications, if you need to talk, you need to talk. Find that support. Clearly, anyone involved, and I think all of us are now vested in Jamaica. Okay, we're a phone call away. I get woken up for people I don't know all the time. Okay, I know you guys. Okay, if you don't need to talk, you need to talk. Mentors should be a #1 resource as you look for people to go through things with. Okay, what do? We care. One of the things I always reflect on is it's more than 25 years, but I've never had, this is an American phenomenon, a lawsuit against me for malpractice in neurointervention. It doesn't mean I don't have complications. I have complications, but I take the time to connect with the patient, but also connect with the family. Because if the patient has a neurologic devastating complication, they're beyond conversation. It's the family who needs to understand what's going on before things happen. So take that time. Now, in thrombectomies, though, again, it's hard. The patient may arrive. You're not going to wait for the family, but if you can reach them on a cell phone, reach them. Just make any connection you can. Once they hear your voice, they know you're working for their loved one. They'll say, "Go get them, doc." Again, it's important. You can look at this crassly, like you're trying to protect yourself from lawsuits, but as you make those connections, and if God forbid you have complications, I've had patients, families send me thank you cards when patients have not had a good outcome. That's very helpful to me. Anyway. Okay, now back to, yes?
Is that we need to understand what's going on in order to solve it, right? So, for example, Dr. Fraser showed a case of an extravasation yesterday during one of his cases, and he said it, like, you need to understand the pathology in order to fix it, right? So what's happening? Why did it happen? To the best of your knowledge and your capacity, where is this patient bleeding from? And what are the steps that I need to take in order for that to stop, right? So what he said, you take one step back, you're controlling, like you're the leader at that moment, right? Like that, obviously, that patient depends on you, and then you just take a breath, and then you think about it, and you just go back to your angiogram. What was happening before, boom, what happened after. Try to time it. Your team is going to help you take care of the patient medically as well. You direct your team. If the patient is on antithrombotics, what can we reverse? If under anesthesia, let's try to control the patient from that standpoint. But you have the catheter in your hand, right? So I think that has been helpful when I've had complications to stop. And again, take a careful look, and sometimes we need to repeat an angiogram. We need to get maybe another certain angle to see what's really going on. And then the other thing that he was talking about, I didn't think of, but I think it's really important for our context here. Obviously, you cannot pick the first 10 thrombectomy cases because these are emergent cases that they're gonna come to you. However, it's good that as you build up that confidence, that you understand that you might not want to be the hero of the century, right? So do not be overly aggressive trying to do things you do not feel comfortable with because, well, this is a thrombectomy case and we got to do what you got to do. Do the best you can with the ability and the knowledge that you have, and you'll continue to build that confidence. And there are places where you will be stuck, and then just call people. We are here.
I tell all of our trainees and my younger partners this. I said, lean in to your complication. The natural tendency, when you have a complication, the natural tendency is to run away, screaming. You want to hide. You want to never come out again. I mean, I've gone home and cried real tears. And, my wife has too about her surgical complications. I mean, it's natural. You're a human, and if you're not crying after your first complication, if you're not crying after your first complication, seriously examine yourself as a physician. It should be tough. It should be hard, but it makes us better and stronger. And so what I tell you is the natural tendency is to want to run away, pretend it didn't happen, move on. Because naturally we want to feel good and comfortable about it. But I'd say actually lean in. Okay, what I mean by that is take that, whatever follow-up you were going to have for that patient, double it. Meaning, if you're going to see that patient in 60 days, naturally, if that's how you manage, or let's say it's an aneurysm, you pipeline it, something bad happens. Normally, you'd see him in 90 days, see him in 30 days, and then see him in 90 days. Increase your follow-up on that patient. They'll appreciate it. They know, because it shows them you're engaged, and if they need something. Like I had a patient once who I had a basilar aneurysm. It had to be treated. It was growing. I had every reason to treat it. And we went up and we dropped a stent and coils. Everything went great except the patient ruptured on the table. Boom. Not from the coils, but from the stent. I mean, just crazy stuff. It's totally unpredictable. And, I spent hours with the family and I had them come back at intervals. And, she needs a wheelchair. And I lobbied personally to make sure to get that patient the wheelchair they needed. Like you take those extra steps with your complications. And, when I went online one time, like we do these days. And, I have to admit, every once in a while I look at my reviews on, and here's this review that's like pages long. And it's like this tome of how awesome I am, and I'm not saying that to you guys to toot my horn, but it was written by the family member of this person that I had one of the worst complications from. I'm like, here I am, I'm like, this person's devastated because of what they went through with me. But it's because I leaned in, okay? So lean into your complications.
It is not what was expected. Obviously, I just echo what they just said. Having that relationship with the family is extremely important. And also, it's not, we're not perfect. We aim very high. We do the best we can every time, but we're not perfect.
So now I was asked about sedation and preparation of the patient. So, tube or not tube? You could read this a little differently. To be or not to be? That is the question. Okay. Scientifically, we don't know. There are all these trials. There have been some experiences reported, et cetera, trying to gauge whether putting a person under GA is deleterious in the overall outcomes of those patients compared with patients who go straight to angio in a non-intubated state. Okay. They're underway. Their validity and applicability to a specific patient will not be perfect. Okay? Their cohorts may not be the patient you're taking care of. the validity of what they study can be imperfect. They may come to conclusions that are inappropriate. I get really frustrated. I've done some paper reviews and such where other editors are allowing authors to draw conclusions that their science that they've done it doesn't support. There's no connection. It's like you shouldn't be able to put anything in a discussion that you haven't proven. Anyway, will efforts that are underway with these research efforts be just the next IMS3 and dissuade us from an appropriate path of care? Next. It's also the only question. So, are you going to intubate or are you going to do some other form of care? Are you going to do local even? I've done cases under local. I've done cases under conscious sedation. But the big question is intubating. LMA and other techniques are typically only implemented if you can't get intubated. If you're going to do an LMA, you should be intubating, unless they can't intubate and they need to protect the airway. All other levels are just not intubating. Okay? Where does all this leave us now? On our own. So, till we have convincing evidence that is applicable to every patient you're seeing, you have to come to your own conclusions. Okay? And we need to account for all the factors that have significance to that judgment. And that is your local environment. I'll say it again later, but most places who are not intubating patients for stroke came to that because they didn't have accessibility to anesthesia support. It isn't because somebody said, hey, let's extubate this patient and do him awake. Yeah, it doesn't work that way. Okay, so what are those factors to consider? Number one, airway protection. We have patients who get intubated all the time just from their stroke because they're losing their airway protection. Patient protection. If they're agitated or if they're behaving in a way that they could decompensate. Okay? And efficacy. So how good is the treatment going to be in terms of time, in terms of outcome? But the first two are the main two, and they come before all else. Okay. So, in assessing relative efficacy of intubated and non-intubated care pathways, you need to know what each affords and at what cost. Not intubating. First glance, it appears faster until the patient moves after you've already acquired a roadmap. Okay, just a few seconds to reacquire. And the patient moves again. Then he moved just a little. And I can work with that. But by that point, you're transmitting devices along the M1, and you don't have the clarity to see that your wire is selected or lenticular striate, that you're on your way to perforate. Okay? So sometimes there's mission creep of getting off your clear path of care. And you have to be careful if you are allowing yourself to be in that situation. There are other troubles that may arise during an awake case that you may want to prepare for. Stimulation during microcatheter access. Further stimulation as you tug on their M1 and the patients experience pain. Okay? And they move. And they can get agitated. They can become nauseous. And you can prophylax that with some fentanyl or sedatives. But that can start a decompensatory spiral as well. Okay? Vasoactive agents may be required that they may not react positively to. Most awake cases don't go that way. That's why VLEs are so calm and comfortable here. But in every other surgical endeavor conducted, patients get intubated. The only benefit on the side, or the only benefit is the potential time saving. However, it remains important to understand that it is only a potential. Any of the aforementioned events would make time fly with nothing happening beneficial to the patient. So, what does intubation cost? Time, but when ritualized, like Dr. Frazier was saying yesterday, I really like that concept. It should add less than 10 minutes. And very often it can even be incorporated into other activities like intubating other parts of the body. I have gotten vascular access as they're intubating sometimes. You don't need to have fluoroscopic access necessarily if it's an easy groin. I don't typically fluoro the groin. Anyway, so other things can happen. If in your environment, if it's allowable, the patient can get intubated before the patient's ready to come into the room. If your intubation staff is going to intubate whether they're in the ER, if it's the anesthetic staff that you're confident in, let them intubate while the team is assembling. Okay? Unless maybe you do need to examine that patient. So that would be a limiting step, but yeah.
Anesthesia gets their radial A line before I get radial access. I'll buy them dinner.
Mm-hmm.
I haven't bought any dinners yet.
Yeah. Mm-hmm. Yeah.
But this idea of intubating first sometimes helps, especially when we were transitioning to this COVID situation and we weren't quite sure these patients can have large vessel strokes, and especially in New York, there was quite a ton of large vessel strokes. We actually developed like a simultaneous protocol, like 2 different rooms. And for the patients who were COVID positive, they were intubated in a different room, in a negative pressure room before the angio suite, just to keep everybody safe. And so, yes, sometimes you have to change things based on your local context. I like that point.
And in that ritual, and Justin said it yesterday, I want to reiterate it, how anesthesia conducts this type of intubation should be different than everything else they do. And they should all know it, that blood pressure needs to be maintained at the patient's normal during induction, and then once they're asleep, it goes up to 160 to 180 till we say bring it lower. And that's typically after we open the vessel. You can change those thresholds, but that's got to be the order. And it often gets forgotten by all of us. So the thing I see lapsing the most often, and very often where I am now, we have stroke fellows who sit in the control room at every case, and they forget. And that's their only job, is to look at the blood pressure. Anyway, okay. And if, yeah?
That intubates persons and then monitors them afterward in the ICU, because I'm neurocritical care. And the point about the management of the blood pressure, especially when you have an anesthesiologist who is not, is a general anesthesiologist, but not particularly used to doing neurological cases. So there oftentimes the choice of induction agent is going to be kind of critical. And then, for example, if you really want to maintain normal blood pressure and the patient's already on the softer side, you may want to use something like ketamine, which, although the standard teaching has always been, ketamine, you should avoid ketamine for neuro patients because of the problems of ICP. Now, more than ever, we're realizing it's really more of a theoretical thing than an actual thing. So we'll use ketamine for patients who are kind of soft, rather than using something like propofol as an induction agent. We'll also avoid combining too many induction agents. So sometimes people will want to combine like a Versed, bendazolam with etomidate, and kind of adding on those different multiple agents kind of contributes to hypotension. And because these patients are in a state of disordered cerebral autoregulation, so even transient fluctuations can actually cause, can change the outcome.
Yeah. And during a case, you're looking to do as many things in parallel as possible, not in series. So the patient should have arterial monitoring during the case. We can get it through our side port if radial access or access to the arterial system for the anesthesiologist is difficult. So I'll say, don't take time, I'll get it. You can work on getting a radial line at the end of the case. It sounds like Justin does a lot of radial cases. When I go to do a radial case, it can be an encumbrance to them because we cannot get pressure monitoring and get an appropriate size catheter in most cases. So they're going to have only one wrist to choose. But, they can go to femoral. Okay. What does it afford? Now, this may not translate. Let's see. Control. Okay. Having an intubated patient gives you control of that patient that is appropriate to any medical act. Craniotomy, bowel surgery, limb resection, and thrombectomy. So you could do a lot of things, but keeping on task, you get control of the airway, of course. Some little things. Every ET tube has an insufflator cuff. Every insufflator cuff has a spring-loaded mechanism to self-seal as you detach the syringe. That spring so often lines up with a carotid or crosses where you need to see over the orbit. Have your staff or you wrap it around the external portion of the ET tube. Maybe put a piece of tape on it if it's going to flap back, but you'll know where it is. And it will usually be out of the way. Very often, you need the endotracheal tube to come out a particular side, especially if you're doing carotid work too. Okay. Now, the other thing, I'm a radiologist. I see things. Okay. I like to watch. You come up, patient's been intubated. You need to know for the care of your patient, and you're the one looking at the screen, whether the tip of that endotracheal tube is down the right main stem. Because if it is, it should be addressed. It was information available to you. It's as if you're looking at a CBC and you're ignoring the platelet values. You can't do that. Okay. So if it's down the right main stem and the left lung is well expanded, you mention it out loud to the anesthesia team. It's down the right main stem. It looks good, but we can't let them leave the room this way. We'll reposition it. But if you have a second or two, it's usually right as you get up to the chest. You're bringing your catheters. You can do something else. Why don't you reposition it now, and then we can check before you tape? So then he'll recheck, retape, and it's good to go. Okay, we have control of breathing. In someone who is not 300 pounds and 5 feet tall, it may not be as important, but that person with a large body habitus, even on mechanical respiration, is going to rock their head. If you're working on the proximal carotid, the vertebrobasilar system, and you're shooting through the petrous bones, you need everything as quiet as possible to see what you're doing. So having the patient paralyzed is part and parcel to getting intubated. If you buy a Cadillac, you get the leather seats, okay? If you have a patient intubated, you get them paralyzed. Okay? And just as in Rocky, you need to have a good watch to have a good time. You need good imaging to get a good outcome. Okay, control. What else does it afford? It gives you control of pressure in any direction you may need. You may be pumping it up, but then the patient may hemorrhage. You may need to drop it down real fast. Okay, things like that. Control of pain. Okay. Patients will be experiencing pain from those same acts that would happen if they're awake. Okay, but it's easily addressed when a patient's completely under general. Of movement, again, that's why a patient should be paralyzed if your case is not going according to the University of Kentucky protocol of 1 hour. And I've never heard of that before. It's a great goal, but how often are you beyond the hour in your practice? Was first stroke. No, it's pretty neat.
For everything.
Yeah, that's cool.
What's that? That's access to closure.
Yeah.
It doesn't include the stuff before.
So, for myself, being inside an angio suite is the place I'm most comfortable in the world. possibly being inside the vascular tree is the most comfortable place. I've had vascular surgeons come into my lab and say, "Oh, Spiegel's here. He doesn't need clots. He needs calendar." So I have a lot to learn. Okay. And of imaging. If you have control of movement, your imaging is going to be better. You may be doing dyna-CTs and things like that. Of case advancement. You have that patient intubated, and you're assuming control. The patient is no longer part of the audience. Okay? He's not a participant, or she, shouldn't be. Okay. Control for how long? At Hartford, we used to keep our stroke patients intubated till the next day so they could have their MRI under general, so we get a perfect exam. Okay? I didn't push that on getting to Houston, but if you're doing that, your critical care has to be better, because it isn't like you're putting the patient on a shelf till they get the MR. The patient may need to be aroused and examined, following pupils. It's putting more on the staff if you don't have a patient who maybe you could otherwise converse with. Okay? And you're not leaving them awake and intubated. Okay, control or lack thereof. How did we arrive at the situation of doing awake thrombectomies? Due to a baseline lack of anesthetic support. No one said, again, as I said earlier, let me extubate this patient and try it awake. Doctors were faced with patients experiencing an exquisitely time-sensitive process, and they didn't have the support they needed, so they moved forward. I do this, If somebody's getting stuck, and Jason said this yesterday, you get the table done. If you're the first one there, you get the table done. If everything else is done and somebody can't transport the patient, you get the patient. This is not an elective case. What was that term? Anesthesia? I don't know. But it goes to all things. Yeah. Okay. Okay. So virtually every practice doing awake treatments of all sorts came to this state from not having good anesthetic support. I can't imagine rupturing a vessel on an awake patient. And as I was writing that was my thought. And then I realized, no, I did rupture a patient who was awake. And put it that far out of my memory, it was that awful an experience.
It's funny that you say this because, okay, if a patient came in who was bleeding out from their gut from a trauma, would anybody take that patient to the operating room and cut open their belly without anesthesia? Of course not.
Mm-hmm.
Like, that would be, whoop, you would never do that. But it's still a time-sensitive thing. And anesthesia would be running like a mad cow to get that patient intubated. So this is really a mindset thing. So when people tell me, if you don't have anesthesia support, what that tells me is, and maybe I'm wrong, and I'm sure there's situations where you don't, truly, but if your hospital is doing anything else in the operating room that is time sensitive, traumas of any kind, where anesthesia is expected to come right there and get it done, then the only problem you have is a mindset problem, where your hospital hasn't said exclusively this is a trauma issue. Yeah.
I do not have anesthesia support. So, and this is the thing. So, so our settings are different, right? Our settings are different. So, you serve primarily how many centers?
3 right now.
3, 1. Okay. So we are 6, 7 later this year. So we're private practice, private practitioners. We serve these hospitals. That's another, difference. We do have an affiliation with the university, so we are academic providers as well. But we work in all of these different settings, and then the anesthesia team is like they have different companies, different private providers too. So these are not hospital employees either. So we kind of all offer a service. And, you know, and it seems like over time, there was, you know, there were significant struggles to try to get the anesthesia teams there for stroke cases. And we just learned to overcome that by training our staff appropriately. The nurses, we got ICU neuro ICU nurses, so they could be the IR nurses. And it is not catastrophic every time. Yes, patients move. Yes, I completely agree with the fact that you think you're saving time, but all of a sudden this patient is moving and you have to, you know, wait a little bit longer in order to get the case done. There are pros and cons. This is totally debatable. If I had anesthesia every time, you know, easily accessible, I would do it. But in fact, again, it seems like, at least in my practice, we've tried to overcome that. And overall, I think we are doing, you know, cases in a timely manner. We are not hurting patients. Our outcomes, I mean, we have a very good neurovascular database, and we can get our outcomes, and we're not hurting people more than anyone else. We're getting, you know, good tikis for our patients. So, you know, we feel comfortable. That's our setting. So, yes, yeah, we work differently, but, you know, I don't want to give this impression that doing a patient under light sedation, if you have the right setting, is completely wrong, because many of us do it that way.
Yeah, sorry, I didn't mean to imply that. What I was trying to say though is, if you're working in a hospital that does other time-sensitive, emergent, operative interventions, like for us, when I went to the chair of anesthesia and I said we want this support, they said, oh, I don't know if we are, and I said, look, we're a level 1 trauma center. You guys can respond to the OR in the same amount of time that I'm asking you to respond to the angio suite. The only difference is the location. And so they shut up after I said that. So my point is, if you're interested in building anesthesia, but you foresee that it could be a problem because you're doing something new, if your hospital, you know, has 24/7 in-house anesthesia that is used to responding to time-sensitive emergent trauma situations, then they should absolutely be able to do this. That doesn't mean this isn't about, you know, places that, I'm not saying everybody should use anesthesia, but to your point of the fact that our lack of using general really came out of the fact that anesthesia was not used to responding to the angio suite in an emergent situation in many places. And so a lot of folks kind of said, okay, I'm just going to do what I need to do, and patients still get great care. That's not the issue. But I'm just saying that if you feel like you're up against that wall and you feel like this is going to be a monumental jump, ask yourself, does anesthesia routinely respond in your hospital to emergency situations in the OR? Because if they do, then it's no different.
Now, something else we're kind of dancing around is one of the limitations, and this often can only be applied as you're developing a program's physical plan. But historically, it started in radiology. It wasn't in the OR. So if you have the opportunity, if you're building a lab, get it close to the OR so the anesthesiologists don't have to walk to the other side of campus. It is an ask in that situation. If it's adjacent to the ORs, it's just another OR. It's another case department. They should be able to expand, etc. What anesthesia requires, and I know because I'm also trained as a radiologist, we are support to most things. And what you need is consistency. It's the inconsistencies that are hard to staff for. So it may be harder at the beginning, but once you're getting regular casework, it becomes easier because they know, oh yeah, we need to hire another FTE because the program's grown so much. You know, things like that. But there will be a growth difficulties with growth. Okay. Well,
What's your question?
Do you have it?
Wait.
Hi, good morning, everyone. I don't know if you can hear me. It's Dr. Wade here.
Yes, you're here.
Yeah, I just had a comment to add to the discussion so far. I think it's a great discussion about the role of anesthesia. And I'd like to share my own experience from my training in Canada. And that I do believe, as they say, you know, a lot of it is a mindset in terms of how your institution thinks and how they are set up. And that if you can find available services to support other time-sensitive emergencies, then certainly this is one of the biggest ones that they really should support. And when I first got to London, they were just starting to reorganize they had a full comprehensive stroke center level 1, but there were some kinks in it, so to speak, and they were trying to build out and reorganize it and some elements of it. And one of the elements was, you know, how to integrate the anesthesia activation at the same time as the activation of the rest of the stroke team. So we actually went through a few different iterations of it. And so in the end, we all helped to kind of come up with a plan or a program as to how we're going to get the attendings or the anesthesia fellow and so on incorporated in the process, so that by the time the stroke case is ready to go, everybody knows, everybody is on board, everybody is good to go. So if the case is a go, then everybody comes and we just go. If the case is a no go, then we tell everybody, okay, all right, stand down. This one is not going to, you know, it's not a suitable candidate and so on. So a lot of it is a mindset, and I found that just being there in that experience, once we got them regularly responding to the new system that we implemented, we found that it significantly improved the overall thinking and feel of, you know, the approach to it, that kind of thing. Not that they weren't doing it before, but it certainly enhanced our ability to respond to these kinds of cases and these situations. So I just wanted to add that in.
Yeah. All right. Okay, I'll keep going. Okay, in summary, you are left to assess your own resources, the patient's particular condition, and come to your own conclusions. But wait, what about the results of those trials? Scrutinize them as much as you do your own actions, because I am so certain that they will give us incomplete answers. Okay? I believed in research till IMS3 told me to stop doing what I was doing, and I knew I was helping patients. And thankfully, the group at Hartford with me felt the same way. We kept going. I remember just a few years before the SWIFT trial came out, and you know, Mr. Clean and such, there were published articles by prominent people in the neurointerventional profession saying we're training too many neurointerventionists. You know, and it was such a hit to what all of us do. You got to really scrutinize any publication that's coming out. So this was a case of a ruptured ACOM aneurysm. So why am I presenting it at a stroke conference? Because we did a catheter exchange. Okay? It is the one act that gets done in a routine fashion that has an unusual association with causing embolic phenomena. So when you have access to vessel that you want to go from diagnosis to treatment, you get an exchange link. Is it better? I can stand up. Okay. Okay. So anyway, you bring an extra long guide wire so you can remove your initial catheter all the way out of the body and still have the wire at the head. So rather than it being 3 feet long, it's like 6 feet long. So you remove that catheter and you replace it with a guide catheter that's going to allow you to transmit the microcatheters to treat the aneurysm. That process somehow has an unusually high rate of causing embolic phenomena. I think I actually have an idea of how it happens. We can get into that offline. But in this case, I'm setting up, right? There's the aneurysm. That's the working view of the aneurysm. Exchange time. Bye-bye MCA. Okay, so we go up with a big catheter and we go fishing, catch the fish. I guess that was it. Okay. Should I stay or should I go? So do you keep going? It usually stops when it's on the mat. Anyway,
Rupture?
what?
Is it a rupture?
I don't remember. This is no case. I don't think so. I think it was elective. It could have. I don't know. I've had them both cases. So it really has to do with how much of an injury do you think it's caused. If you got this out, if you recognize it immediately, because sometimes all of a sudden you're seeing a branch occlude and like, let me look back. Maybe I'm just noticing it. Okay. One of my other things I do in my practice when I'm doing aneurysms, I get that working view. I also get a full headshot of the working view before I get started. And anytime I do an exchange, I do a full head view after to prove that I didn't embolize. So if something looks funny along the way, I'll have a full working view of the whole head to refer back to. Because if you only have AP and lateral shots and then you're at some oblique, then you're wondering, is that branch there? And whatever. But so if I get it out readily, and now it happens more often than not, I'll go on to treat. If I think I may have caused a secondary injury, I might not feel good about it. If he's with me with this disastrous case. Oh my God, I'm like getting sweaty. Relatively young woman, giant aneurysm. We were going to coil and put a pipeline or something, and we recognized that she had a small perforation, probably from a distal microwire that must have jumped or something. And we said, well, we're not going to put it in the pipeline. We thought it was controlled because it would have committed her to aspirin plaques. So we're not going to do that in the face of hemorrhage. And we thought we had it controlled. We didn't have it. It was awful. Anyway, but you want to be able to recognize as soon as you can. So this one went on, put it in the coils, got the job done. And that other thing hanging down is just an infundibulum here. Okay.
So I think we should be breaking here. Thank you. Thank you so much.
Thank you.